Hello! Here we are reaching quite quickly the end of this first day, but still with two wonderful presentations to go. I really hope you are enjoying so far. Now we travel to Africa and to the beautiful city of Cape Town to meet our South African friend and world-renowned speaker, Dr. Howie Gluckman. Howie first got his dental degree at university in Johannesburg and then completed it with distinction a 4-year full-time degree in oral medicine and periodontics at the University of Stellenbosch in Cape Town. He was intimately involved in the development of the postgraduate diploma in implantology at both University of Stellenbosch and late at the University of Western Cape. He is currently in full-time private practice in Cape Town. Dr. Gluckman was always linked with many important South African scientific societies and has lectured extensively nationally and internationally. Howie is now a member of Dentsply Feerden's Masters Speakers Program and he is on the experts panel of the international educational website Dental XP and on the Dental XP Scientific Board. Dr. Gluckman has been involved in implantology training for 18 years and is the director of the Implant and Aesthetic Academy, which is a private postgraduate training facility in South Africa, which provides education in implantology and aesthetic dentistry. I am proud to leave you with Dr. Howie Gluckman's presentation on partial extraction therapies. Let's watch every detail of his conference. See you in a couple of hours.
Good evening and welcome to this session of the International Masters. In this session we're going to be dealing with partial extraction therapy, and I say hi from South Africa. My name is Dr. Howard Gluckman. I'm a periodontist and an avid user of partial extraction therapy as well as bone augmentation and immediate implant placement. I think the essence comes down to extraction therapy actually come from. It's obviously something fairly new. The publications are only 2016 and 2017, but essentially a lot of the stuff really stretches back quite a far way. And if we have a look at this article by Ferris where they talk about the factors that influence ridge alterations following immediate extraction placement, this is really where everything has come from. In about 2009, Boozer and Chen stated quite categorically that we should not be placing immediate implants anymore. And it really was to some degree quite a turning point for us, because we started to look a lot more deeply as to why we were actually getting so much collapse of our tissue, and that really was the issue. And if we look at the study, they showed that there was more bone collapse when there was 1 millimeter less. We had more recession and buccal collapse when we had thin gingival morphotypes. And if you have a look at this as one of my cases, you can see on the right hand side the normal emergence of the tooth, and you look a little bit to the other side where the implant was, and you've got this whole collapse of the tissue. And if you look on this one, you can actually see a change in color of the tissue that one gets as a result of this collapse. Now this is only a single tooth. You can imagine what would happen if there are multiple teeth and if we get that type of collapse. The whole essence comes down to the resorption of the buccal plate, and Myron Nevins in 2006 showed what happens within 3 months. If you look at the the ridge collapse that happens in this article, they showed Arroyo, which I'm sure most of you will know is a classic article where they show massive resorption of the buccal plate and around 20% collapse. What's interesting about this Arroyo article, if you look at it really critically, the type of socket that they've got there really is an upper premolar socket. It's not really one that looks like a normal anterior socket where you have very, very thin buccal bundle bone. So whether one can actually use this to extrapolate on all cases, I think is probably maybe a little bit of underestimation as to how much destruction that we get. So we get the type of destruction there as shown, and just 20% less. So the whole concept of it was basically that we lose the bundle bone. So we all know that bundle bone belongs to the natural tooth, and the minute you take out the tooth, the bundle bone disappears, mostly because of the loss of blood supply, which is supplied by the periodontal ligament vessels. And we all know that bundle bone embryologically comes from the tooth bud. So take out the tooth, the bundle bone goes. And that's why we know that if you have thicker than 1 millimeter, you generally tend to have a much more stable bundle bone rather than when you have a thinner buccal plate, as we saw in the Ferris study earlier. So with bundle bone, there are two factors. If you have a look at all the different cases, you can see all the different levels of bundle bone. We can see on this side where we've got a very thick bundle bone. Over here we can hardly see it. This one is almost non-existent, again non-existent, and really a very, very difficult thing. And this is where apical bone also plays a role, because the apical bone in immediate placement really becomes a major issue, because it is this area over here where your stability of your implant is going to play a role. So it's very important that we understand that it's not just the bundle bone that's going to be a factor. It is also apical bone that's going to give us everything that we need in these cases for stability. So from around 2011 and a little bit earlier, we started with Uli Grunder started with this great article that showed really that the tunnel technique really gained, when you started placing connective tissue with immediate implant placement, it really compensated for the type of collapse that we had. And more recently, the Aganini brothers in IJPRD in 27 developed the concept of the veneer grafting, which showed pretty much what we've been doing for many, many years, which is really just doing a connective tissue graft. And it's really taking care of the soft tissue profile and preventing the collapse and the recession resorption that we have when we do extract teeth. So if you have a look at this case, you can see what the bone looks like or what the ridge looks like in that case. We've extracted the tooth, we've retrofitted the same tooth back, which is something I like to do. I call it walk out as you walk in. Maria Steigmann presented on this, wrote on this in 2007 in IJPRD, and just fitting the patient's own crown, putting a connective tissue graft below using a tunnel technique, a very, very nice expansion. And what this really does is this really prevents the recession and collapse of the tissue that one would normally have when, as explained by Arroyo and Nevins, when one extracts the teeth. So here you can see at healing and integration, you can see the beautiful result that's been achieved. Not only have we increased pretty much the same as Uli Grunder stated in his article, but you can also see in this on the left, you can actually see that we've actually brought the soft tissue down. So instead of getting the recession, instead of getting the buccopalatal collapse that we know happens from Chen and Boozer and Ferris and all the other guys, we are actually now expanding it. So this is really a technique that we've developed really for single teeth, which allows us to manipulate the biology and allows us to really expand the tissue and prevent what was happening. And as long as the implant is placed in the correct three-dimensional position, and as long as there's good enough apical bone to stabilize our implant, an immediate implant really can work very, very well. And with narrow diameter placed more palatally, we should get both bone over it, and we should get good soft tissue stabilization using this connective tissue graft. But let's have a look at thin gingival morphotypes, because really thin gingival morphotypes is something that we really need to look at. And one of the things with thin gingival morphotypes, as you can see, which comes from Joseph Kahn's article, which is really just a consecutive case report. And here what we have is we have a situation in thin gingival morphotypes where you can actually see in this case where we had the same situation as I showed before. We extracted the tooth, placed an implant, did a soft tissue graft, and 1 month afterwards you can see the soft tissue's pretty much gone back to where it was. And this is the real problem with thin gingival morphotypes, is it really something that we can reproduce? And certainly in my hands it's not. And more often than not, in thin morphotypes we tend to lose tissue more than gain. Here you can see the same case 3 years later, and if you look at the periapical, you'd look at it and say, "How that's actually really a fantastic result." You look at the X-ray, the mesial and the distal bone is pretty much sitting in a very good position. But look at the CBCT, and you actually see that you cannot see any bone on the buccal of this implant. Could I have placed the implant more palatally? I don't think so. If you look at the CBCT, could I have used a narrow diameter? I'm using a fairly narrow 3.5 millimeter ankylosed implant, so something not really. So this is possibly a case that either should have been done as a delayed approach, as described by Boozer, but certainly a veneer graft type situation in this kind of case is really not gonna work. So we need to find something that's going to work for this. If you look at the 3-year post-op, you can see what's happened. We've got gingival recession, we've got buccopalatal collapse. So all the work that we did to try and do the veneer graft, we actually haven't worked in that regard. So we have to understand that a lot of these techniques have limitations in what we can achieve. Here you can see another case that we did in around 2008, and this was a classic type of case. Again, the same thing, we extracted, the buccal plate was intact. I still placed a membrane in those days. We were trying to do extra work. We packed the jump gap with bone, with xenograft, which is non-resorbable, pretty much doing everything that everybody says. The tooth next door required an apicectomy. We did the apicectomy at the same time. And here you can see the healing process, and everything was looking pretty good. You can see everything looked here. This was a 4.5 millimeter implant placed with a standard abutment. There, the apicectomy, you can see successfully done on the tooth adjacent, and really not a bad result. The problem is that if you look at a tooth like this, even with everything the way it is, the question is this going to remain stable over time? And here you can see in 2008, the patient hasn't even taken out the crowns and replaced it. So this is still the temporary that the patient's wearing two years later. And really not a bad result, but you can see some recession starting to take place around the implant crown, as you can see from where I show you there. If we have a look at what we've got here, you can see on the left-hand side, we take everything off. We've got buccopalatal collapse. We've got a little bit of recession. Pretty much everything that you would expect, but still, nonetheless, we've still got pretty good soft tissue. Now, the problem is that soft tissue itself doesn't tell you anything, because the question comes now, is there bone over there or isn't there? And it doesn't really give you the answer, because the bone itself can be the soft tissue itself can be stabilized by the bone on the teeth on either side. And if we have a look at this case, you can actually see the collapse that we've got there. And here we just did a little bit of extra connective tissue grafting, again 2 years later, and really getting an acceptable situation, an acceptable aesthetic outcome. Patient was happy. Our papilla are still in the same place, so we've got stable papilla, we've got a little bit better emergence profile of the crown, and pretty much not a bad result. Fast forward 6 years later, and this is what the patient came with. They came with a situation where they had these draining sinus on the buccal, and really the apicectomy that I had done in 2008 had failed 8 years later. And unfortunately, we were not there to extract the tooth or to probably limit the extraction of the tooth, and the dentist took the tooth out, allowing us to do everything. And if you look at it, we've lost some bone on the distal. The mesial bone is still looking pretty good in that area. And more importantly, when we open up to see what's going on here, which is the most shocking part, is you can see what happens. So long term, these kind of things, although we seem to have soft tissue that looks stable, the question comes down to, do we actually have bone on a lot of our cases? And in a lot of our cases, there actually isn't bone. And sometimes we do delayed approach, sometimes we do immediate approach. And in both of them, the question comes down to, do we have good bone in all these cases, and sometimes not. And this really gets exacerbated when we're doing multiple teeth. We do ridge preservations, we do socket preservations. In this case, we did the socket seal technique by Kobe Lunsberg described. We did ovate pontics, we did bridges, provisional bridge to try and support the papilla. We did everything that we could that most people would do these days with the type of ridge preservation techniques. And still, if you look at the case 1 month later, you can see what we had to start, and you can see the massive collapse that's taken place as a result of the extraction of 3 teeth in this area. So extraction of teeth really is something that is a massively debilitating situation, because the problem is we don't know how much that patient's going to collapse. Are they going to resorb a lot? Are they going to resorb a little? And there really isn't a test that we can do that will determine it for us. If we look at pontic site development techniques, and we look at this Vinoletti's systematic review, one of the essence of the systematic review, that despite the fact that we do all these fantastic ridge preservation techniques, and we do soft tissue grafting and all the stuff that we do, and we place our implants in the correct position, if you look at the case, you can still say to me, hey, Howard, not a bad result. We've got a fairly good emergence profile. But the minute we put that together with the lips, you actually get to see, despite the incisal edge being wrong, the gingival edge is massively wrong in this case by the restorative dentist. And as a result, the aesthetic result really is a poor result, when in actual fact, shown without the lips, I could quite easily lie to you and say, look, what a fantastic result. You say, wow, great emergence profile, etc., etc. But essentially, there are no papillae, the whole thing's collapsed. So these are the problems that we're dealing with. And if we go even further into full arch rehabilitations, this is the kind of scenario that we see most often at conferences. We see the lovely emergence profile, we see pseudo-papilla formation, and we look at ourselves, we pat ourselves on the back. But the problem is that predictable? Can we achieve that on a daily basis? Or is this more the kind of thing that we see with a lot of our cases? And I think if anyone's really honest with themselves, the more they look at their cases over the long term, 14, 15, 20 years, these are the kind of things that you're going to see. If we look at another case of mine, and these are all my cases, if you look at another case of mine, 7 years post-op, and this one 13 years of the same course, it's the same patient, 13 years post-op, just continuous recession, resorption. Where's the bone going? Why is the bone going? And the crux comes down to the fact that we actually don't know. This is obviously a very severe case, and it doesn't happen all the time, and we do get a lot of cases that are really cool and they look great. But the key factor for me is, can we guarantee this in every single case? And the answer is no. If I take the teeth out and I do delayed approach and I allow everything to collapse first, can I guarantee that that case isn't going to end up like this case? And the answer is no. And I think that's where the whole concept of PET comes in. And I just have to give a little bit of gratitude and a mention to the group that I work with around the world, to Salah Huey, Chuck Schwimmer, Jorge Campos, Armando Pozzi, and Shnezana Pol, and Rich Martin from around the world. We are doing some multi-center studies, and certainly this is the group that has helped develop on the Dental XP forum the whole concept of partial extraction therapy, which myself, along with Maurice Salama and Jonathan Dutoy, published the first article in IJPRD in 2013. The second article came out in IJPRD 2017, and for anyone who would like them, please email me and I'd be happy to send you these articles so that you can get an idea. And really what they do is they describe the concept of partial extraction therapy, which I think is self-explanatory. Partial extraction, in other words, we are not extracting the whole tooth anymore. We are trying to maintain some of the tooth, and by doing that, trying to prevent the collapse of the ridge. Partial extraction therapy really comes down to 3 topics: socket shield, root submergence, and pontic shield. And those are the 3 concepts that one talks about when we're doing partial extraction therapy. But root submergence really was the one that started the whole concept of partial extraction therapy, and really it goes back as far as 1975, but really was made, I think, a lot more brought to the fore by Maurice Salama and Ishikawa in this 2007 article, where they spoke about the advantages of root submergence in implant therapy, which really wasn't something that was being utilized at all. So here we can see going through the concept, and here you can see this is from Garver and Fenster in 1980, where they spoke about vital root retention. So in other words, they were keeping vital roots. They weren't doing root canal treatment. They were actually just decorticating them, as you can see in this case, taking off the top and just sinking the whole thing by 2 to 3 millimeters. So, and then what happens, covering it with some soft tissue so that you can get nice healing, and then you can then create an ovate pontic over the top of that to get beautiful wound healing in that area, as you can see from the slide. So this is really the whole concept of root submergence, and really it's an old tried and tested pre-prosthetic treatment. And the whole concept of PET really comes from this. If we look here at another 1983 article by Lambert, and here what they did was, the whole thing was about the free autogenous graft coverage of vital roots, and really it was just a technique to cover vital roots. And we also know from the histology from these vital roots that what happens is that once you sink these below the bone crest by 2 to 3 millimeters, what happens is that you actually get new dentine formation sealing off the vital nerve, and then bone formation over that. So the whole thing remains vital, because that's one of the biggest questions that people ask is, well, number one, isn't it very painful? And the answer is 0. The patients have nothing. And the second thing is, don't they have, doesn't it die, and isn't there a risk of endo problems? And certainly if the tooth is not vital, or if there's a hyperemic pulp, etc., and things like that, one should not be sinking them without a valid endo or other techniques, which I'll show you just now. But certainly one can sink them, and one can, without any worry or problem, get these sorted out. Here you can see a case that I did in 2006. You can see the preoperative, the post-op in 2006. She was involved in a motor vehicle accident. We did a little bit of gummy smile treatment. We did an implant in the upper left lateral incisor, and she was pretty good. And she came back in about 2012. You can see the midfacial growth and the discrepancy here. She's about in her early 40s now. That was described by Carl Misch, and she certainly had some of that. And her problem now was that the upper right central was very, very mobile. She couldn't chew on it. The upper left central was a little bit mobile, and she had some discomfort. And when we examined it, we found that there was actually some external root resorption on both of these teeth as a result of the orthodontic she had post accident, and possibly the avulsion from the trauma as well. But most importantly, if you have a look at this case, you can see how beautifully integrated the implant is in the crown there, which meant, and the papilla that we've got here. So it's really something that we didn't want to mess with, because this is really was a high aesthetic value patient. She was high aesthetic value. She was a very demanding case, but still a lovely lady that really we wanted to really do well for. If we look at the pre-op CBCTs, you can see the upper right central. You can see the massive resorption of the root, most likely due to the avulsion. In the upper right root, the upper left root, you can see the root resorption that was taking place. And on the lateral incisor, you can see the phenomenal bone that we've got growing around this, and the 2 millimeters bone that Uli Grunder talks about is certainly present, which gives us that beautiful soft tissue integration that we see around that implant. So in this case, what we decided to do, we decided to do an endodontics of that tooth. The central was not possible to do anything, so we extracted that tooth. We placed an implant in a more palatal position, in a deeper position, a la Cavani's recommendations when he spoke about the bone remodeling around implants. We did biodentine to fill up that area to prevent any more resorption of that area if possible, and we sunk it with a rotated palatal graft described by Carlos Nemkovsky in the year 2000. Here you can see we left the thing maybe sitting a little bit proud. You can see the post-operative x-rays and everything looking good in that area. And here you can see the integration assessment at a later stage. This was done about 4 to 5 months later, and you can see how beautiful the soft tissue is, and you can see the maintenance of that ridge. Now some people will say, yes, but I can do that with bone alone. Absolutely, but the question is, can you guarantee that it's going to stay that way? And the answer is definitively no. You're going to get some collapse, whereas with the root being in that area, it's certainly going to stay. And here you can see the case 1 month and 14 months. You can see how phenomenal the bone, the soft tissue emergence is of the crown placed as a cantilever from the adjacent tooth. From the occlusal part, you can actually see again the beautiful bulk that's been created from the rotated palatal flap, and the bulk that's been maintained by the patient when she smiles. And you notice the papilla on both of these where there's an implant, a retained root and another implant. You can see that achieving this kind of aesthetic result, in my opinion, and some people might disagree, but in my opinion, there is no ways I could have predictably, and I repeat that, predictably, there's no ways I could have predictably achieved the kind of result I got had I not utilized the technique that I used here. Here you can see the case again 5 years post-op, and you can see how beautiful everything's maintained. There is zero collapse of the tissue, and even though I've got an implant on both sides, none of these are collapsed because of the fact that they have a tooth either side of them, and that tooth will maintain the bone, the soft tissue profile on the implants and everything around, and keep everything intact. And I'm sure most of you will agree that if this is what it looks like at 5 years, there is no doubt that at 10 years we will have the same thing in the same way. And here we go, the post-op radiographs and the post-op CT. Okay, so sorry, this is not a post-op CT. Here you can see this is another one of my cases. This is 1 year post-op, showing the bone growth actually happening over a root submergence in the 2-3. So you can see on the left-hand side, you can see where we did the vital root submergence, covered it up with some soft tissue. And here you can see that 3 months post-op, you can see the bone starting to grow into that area. And at 12 months, you can see the beautiful bone, how it's settled over the top of the implant with the vital root. And now you've got something that's going to really hold everything in place and keep everything together. And I think this is the key to success of this treatment, is correct application, sinking the bone deep enough so that there's, sinking the root deep enough so that there's space for that bone to grow over, giving it full coverage so that you can maintain it. So the whole, the root deep enough so that there's space for that bone comes from and is taken from the whole root submergence technique. And Hertzler and Otto Zur really in 2010 really, I think, did a phenomenal job in giving us this proof of principle report where they showed and they concluded that retaining the buccal aspect of the root during implant placement does not appear to interfere with the osseointegration and may be beneficial in preserving the buccal bone plate. And that, I think, was really the change and the massive paradigm that we had to actually have this kind of thing. So when is it possible for us to do the socket shield, and when are these kind of things important for us to do? And the important thing is that we need to understand that intact buccal bone is absolutely essential. We cannot do socket shield, we cannot do the other techniques if we don't have intact buccal bone. So in periodontal disease really is a major contraindication because of the fact that when we have intra-bony defects and things like that, generally there's perio disease, and we don't want to leave any of the bugs behind. We don't want to rely on a root planing or some kind of trimming of the root to do that. Saying that though, if we can trim and there is good bone all 360 degrees around it, you can use that. Internal and external resorption is definitively not a contraindication. Certainly the group that I'm working with have found that you can do it in all these cases, and there doesn't seem to be any issue with these kind of problems. And I think most of you who will have seen root canal treated teeth that have really resorbed and over time and due to trauma, and where you've actually got no root left, you notice that there's no collapse of the ridge anyway. So I think that this is something we will certainly find out in the future, but certainly our early indications are that there's no issue doing it with internal or external resorption. Looking at the initial histology that was shown by both Marcus Hertzler using emdogain on the left and Daniel Bomer, who comes from Marcus Hertzler's group with no emdogain on the right, you'll see, because this is the critical thing that everyone asks, well, what happens between the root and the implant? And as we can see from these animal studies, that the whole issue is that we get bone formation, and that's the fantastic part, is that we do get bone formation. And the whole thing about this is where the key is, and why this has potential to be such a successful technique, the socket shield, is that the bone forms there. The second thing that we're looking for is we're looking for long-term data, and Schompras and Mitzias came out with this article in 2014, where they had about 46 cases, and they showed out 46 cases, and they showed patients, they had 24 to 60 months of follow-up. Now, the one thing about this article, although it shows us 100% success, the one thing that they didn't mention was whether they had any complications. And by complications, we mean internal or external exposure, mobility of the shield, etc. And we know from, if you look at the article and you look at the way that they prepared the roots, a lot of them had the shield exposed, which is really not something that we want to do. So whether we had 100% success in this article, really, I think we have to question. There's no doubt, There's no doubt internal exposure, they had no clinical problems, but I think until we get some consensus on whether internal exposure is a problem or not, me personally, I do not want any exposure of that shield at all. I want to keep it absolutely stable and intact. The second article, which I think is very, very, very important, is the socket, is this Bomer article where they looked at volumetric data after 5 years. And this was published in 2017 in Clinical Oral Implants Research, which obviously is one of our top journals. And the interesting thing about that was that what they said, that within the limits of the descriptive study, the socket shield technique offers reduced invasiveness at the time of surgery and high aesthetic outcomes with effective preservation of the soft tissue contours. So what the volumetric data showed was that there was actually zero collapse. And in fact, one of the cases, they actually had expansion. They put it down to incorrect scanning of the models. But I think the other thing that could have happened was that there might have been some migration of the membrane, which I'll show you in some of our cases, which can happen if you put a little bit too much pressure on the membrane when you're turning the implant in. But here you can see the way they did it. They did subtraction analysis using the models that were scanned in, and they found that in essence there was very little, if any, change. From, you can see they put the neighbors on the left and right together to find that there was no change, and you can see from the radiographs as well that there's no loss of bone at any stage after 5 years in all of the cases that they did. So let's look now at a little bit of the upcoming data, some of the new data that we are starting to get. And the first thing that we look at, and this is unpublished data, so please take it from whence it comes, and I have to thank Gali Implant and Jorge Campos for this stuff. But if you have a look at the data, you can see from the root resection, when we left the root 1 millimeter above the bone, you can see that in all the cases there's bone growth right up to the top of the implant, and wherever there was contact, it actually moved away and we got bone formation. If you have a look at this one, again, exactly the same type of situation, bone formation between the implant and the piece of root. And I think that's the critical issue that we want to see on a regular basis, and that's the biggest question that we have. But where everything changed quite dramatically was when the bone started, the shield started being put at bone level. And this was a fascinating thing, because once we did this, if you have a look at this was much more impressive, because not only did we get bone formation between the implant and the tooth, but what happened as well is we actually got implant bone growing over the top of the tooth. And now I think this is something really phenomenal, because for the first time now we've shown that you actually get the bone encased, the actual tooth encased in bone. And I think that's really something that's really important. Obviously, what we need to do now with this is we need to do far more of these, and we need to now do control trials with these to check and see that we can get this on a more regular basis before we publish it. But this is certainly something that's very, very exciting. The other thing that's exciting is the the unplanned socket shield. We got some human stuff which will come out in JOMI in 2018. And essentially what happened here was that a piece of tooth got left with ligament fixed to the bone. And when the surgeon saw that, he actually went and took the whole thing out en masse, and everything was connected. He didn't realize what he was seeing, and there was no pathology there at all. Everything was nice and healthy. And when it was sent for histology, the interesting facet that we saw is you can see the type of bone formation that has taken place, and also the dentointegration, in other words, the integration of bone to the tooth. And we're seeing this more and more now when we look at the histology of the tooth bone concept, which is being pushed by Dong Sok Song from Korea. And essentially they show the same thing, where these pieces of teeth have this actual dentointegration with bone. And this is certainly what we saw in human histology. There's also a new histology that's come out from the Greek group, which is 10 years post-op, where the patient had a motor vehicle accident, and it shows exactly the same thing as I'm showing you here, where there's actually bone growth between the implant and the shield, which is absolutely fantastic, because now for the first time we actually have human histology showing us the same thing. So let's get now to the latest publication, and this is accepted for publication in Clinical Implant Dentistry and Related Research. And this is our article, which will be coming out very, very soon in this journal. And this is really one of the first articles which showed us a large proportion of cases, and certainly a large number. We need over 100 cases, which I've been certainly told by Danny Boozer many times that anything less than 100 is not really an article. So what we did is we did a retrospective case series of 128 cases, and we had a gender mix of about 70 males to 58 females. We had 1 to 4 year follow-ups, and the number of complications we had was 25, and I'm going to go into them in detail. We had 5 failed implants, which gave us a 96% success. And I think that's quite important, because it really fits in with all the other data that we have, whether you're doing early, low, immediate placement, whether you're doing delayed placement, all of them are having the same thing. So the most important thing here, number one, is does it succeed the same amount of time? And the answer is yes. And the second thing is the number of complications. If we look at the follow-up period, we had 16 in 2013, 57 in 2014, 32 in 2015, 23 in 2016, for a total number of 128 cases. The tooth positions were mostly in the central incisor area. 46 of them, laterals being next, canines next, and premolars. Molars, I hadn't done very many. I'm now doing a lot more premolars after seeing the phenomenal results that have been achieved by some of my co-workers around the world. If we look at the complications, we had a 19.3% complication rate. But the interesting thing is we have to look at these complications, and people will say, well, sure, 20%, that's a lot of complications. But we have to look at what type of complications they are. And if we look at the majority of the complications were internal exposures. And this is still a point, although I call them complications, a lot of people say, like the Greek group, which say that they don't see it as a problem. I do see it as a problem, and it's something that's fairly easily managed, as is the external exposure, where these are both really relative complications that one would have whether one's doing a bone graft or any other type of procedure that one is doing. that requires a fair amount of skill level, there is the possibility. But the interesting thing is, now that we've changed our protocols, which I'll go into it with you, we now have far less of these complications because of the fact that we've now, along with the data, been able to change it. Shield failure we had in about 3 cases, and all of those were very much in the beginning phases. We don't have any shield failures anymore because we know what to do with regards to the thickness, and most of those were where I tried to thin the shield out too much, and as a result of that we got a flexible shield which caused failure. Of those three shield failures, okay, we had we had 2 of them had implant failures. We had 1 shield failure that didn't have an implant failure, and we had 5 implant failures. And whether the implant failures were related to the socket shield, whether they were due to the socket shield, I think is a questionable issue as well. And the last one is shield migration, and this is an interesting one where a little bit of pressure was put on. We had internal exposure. A little bit of pressure was put on when the crown was screwed down, and as a result of that we actually had orthodontic movement of the shield, which I'll show you now. So here you can see what we have in this kind of scenario, where you can see on the left and the right, you can see the shield exposure over there, and you can see the kind of red and raw type of situation, as opposed to on the right hand side, the premolar, you can see absolutely beautiful soft tissue, and that's really what we're looking for in my opinion. But despite that, I want you to still have a look and see all the beautiful profile of the tissue on the outside and how beautiful it looks. So despite the fact that we had internal exposure, the question is this really a major problem? The way we deal with it is we generally cut it down to around the bone level, and we put a little soft tissue graft over it, and that generally covers it up without any further problems whatsoever. External shield exposure, you can see in this case a heavy smoker. We did root submergence as well as external as well as socket shield, and you can see the problems that we had with the external exposure due to that. And here again, all we did in this case was a little bit of soft tissue grafting, trimming it back, soft tissue grafting, and everything goes back to perfect health. And now we have that beautiful ridge. And most importantly, if you look at the density and the thickness of this ridge, this is not achievable in this type of situation if we do not have the kind of partial extraction therapy techniques that we've utilized in this case. This is the one case where we had shield exposure. This was due to the flexibility of the shield, and you can see on the left hand side where we had this kind of problem that we had there. We opened up, we took out the shield, and we did some GBR techniques. We did bone and membrane, and we placed everything in position, and this implant is still 4 years down the line stable and happy, and pretty much without any further complications. Just to show you the high up of the thing. Here you can see one of the cases where we had a failed implant, and you can see how beautiful the emergence profile in this area, and you can see still everything looking fantastic, but the implant unfortunately wasn't integrated. And you can see here how phenomenal the bone is. You know, we could take out the implant, we could put a new implant in, we could pack it with bone, and we had no issues with everything. This is a case where we had in the cases where we had 2 cases where we had both failed implant and failed shield, and in both these cases we took out the implants and we replaced it with normal GBR techniques, and here you can both of those cases are nice and happy. Here you can see a case with a shield migration. You can see the beautiful 2 implants with their socket shields, the beautiful emergence profile. And you can see here, if you have a look at this case, you can see how the crown there is just touching the shield a little bit. And as a result of that, you can see how this popped out. There's still bone formation between the 2. There's no change. You can see that in this area, you can see a little bit of what looks like thickening, but it's absolutely symptom-free, painless, and the patient has got no problem. So we leave it and don't touch it in any way. So here you can see the technique that we utilize to do the socket shield. It's really a root resection technique where we utilize root resection drills. And this is really something that we've changed from the way Marcus Hertzler and also the Greek group, because they really take implant drills and drill straight through the tooth, which is something that really I don't advocate, for the pure reason that it's done with a slow handpiece. It causes a lot of vibration and you can shake the root loose and cause complications. So here you can see just the way that we do the whole thing. You can see there the piece of tooth using sharp root resection burrs, cutting a C-shaped groove in the top of the implant and really sectioning the buccal and the palatal very carefully and very gently, understanding what the direction of the shield is. Obviously we can't go through and give you exact things, but you can see the C shape, making sure that everything's off, removing the palatal section, keeping our finger on the buccal to make sure that there's no movement of that buccal portion, and slowly preparing our shield. At this stage we were doing it not to bone level, these days we're doing it to bone level, following our article where we found where the internal exposure being the biggest problem. So there's that shield in position, pretty much our implant placed at the right position, utilizing the Megagen system, which is obviously my preferred system, I use most often. Standard protocol of preparation. These days as well, what we do is we use the Versa drills, which helps to densify the bone as well and gives us better primary stability. You can see in the mirror the palatal placement of the implant, placing the implant into position in a palatal and slightly deeper position. Excellent primary stability with these implants so that we can do immediate load. And there you can see everything intact, and now we can fill the jump gap if need be. So here you can see the case that we showed before. You can see here how we've got the jump gap that we've created. We fill it with bone. Some people think you don't need to fill it with bone. At this point in time, we don't have any data to show whether filling it is necessary or not. I prefer to fill it to stabilize the clot that's in there and make sure that we don't get any change. Here you can see the provisional place, whatever the crown was, we put it back in. Not a great looking one. But there you can see most importantly what the soft tissue looks like, and that's really what you're looking to get. You're looking to get really beautiful, healthy soft tissue with unbelievable emergence, and now you can start to create everything that you need with emergence from the crown using customized abutments. And here you can see the 3-year post-op of this exact crown. You can see the crown in place. You can see the beautiful emergence profile. If we look at the CBCT post-op, you can see that the buccal bone plate is still there. It's 100% there. You can see the interproximal portions, how they will maintain the papillae. And if we ever have any collapse at a later stage, the most important thing that's going to happen here is that we're going to have the interproximal papilla staying in place because of the fact that they've got good bone. Here you can see the technique step by step and how we've changed it. We section off the crown, pretty much the same as you would do for a root submergence. But now the next thing that we do is we actually take a cut and we cut it through in a C-shape type position, so that we extend from mesial to distal, taking out the tooth, the palatal portion of the tooth, including the root canal and including the apex. The next thing that we do is we prepare the shield portion, and here you can see what we've done now is we've actually started to create a chamfer, an S shape, and this is what we call the prosthetic space. And this is a very important space because this prosthetic space is what's going to give you enough soft tissue between the crown and the abutment, the subgingival portion of the crown and the abutment, to allow good coverage and prevent the internal exposure, which, as I said before, is something that we don't have too much anymore. So here you can see the implant in position. We then place our bone into position, packing the bone, and also doing pretty similar dual zone therapy a la Dennis Tarnow and Stephen Chu to support the soft tissue that comes out. And here you can see everything in position, the crown in position. And here is placed just above the chamfer level so that you can see that we end up with a 2 to 3 millimeter distance that allows good emergence profile, and that will fill in with soft tissue and allow that shield to be nicely covered and not exposed. And that's what's going to give us the healthy situation. And here you can see 3 years post-op where this patient has still got no recession and resorption on the implant, but the adjacent teeth there is recession, which is quite interesting to see in this 3-year post-op case. Here you can see another case. What's interesting in this case is this case we actually did, if I go back, we did here with the normal Hertzler technique. And I want to show you one of the second problems that happens using the drills. If you have a class 1 type defect, implant tooth position, you can see if you drill straight down the root canal, it's not a problem. But here, when you have a class 2 situation and you start drilling, the risk of you actually perforating the apex is quite high. And this is why it's rather better to use a high-speed handpiece where you can control the angulation and the direction. But again, the same sort of thing. We've created the shield technique. It's something that you need to do a course on to learn how to. But again, the same sort of thing. We've created the shield. We've developed the shield. We pack it with bone. We've reproduced the crown, put the crown back on the whole situation. And you can see the beautiful emergence profile that we've created here. Still absolutely zero collapse. And these were done 9 months later because these were some of the beginning phases. And everything's still intact and beautiful soft tissue. And the most important thing here is that there's no membrane. There's one little bit of bone. There's nothing else utilized, and it's one surgical procedure. So there's no doubt that if we can get the same sort of thing, and here you can see the 4-year post-op photograph with zero collapse, and we've got absolutely perfect soft tissue, perfect no collapse of the tissue, and we've got absolutely stunning papilla there. Now, obviously, people will say to me, yes, well, Howard, the papilla is great because the teeth either side is, and the bone on either side is what's going to maintain the papilla. But in essence, if you have a look at it and you see the x-ray, what we really have here is 2 implants next to each other. And if you see where the bone is sitting purely because of the fact that we have done socket shield, I think this is where the socket shield really outstrips every other technique, is the fact that we are able to maintain interproximal bone long term. And here you can see 4-year post-op. Here you can see the situation, what everything looks like, and I was able to take the crown off and to have a look and to see the healthy tissue that we have. And here you can see what everything looks like, all happy and healthy. If we have a look at this other case, a DSD case that we did, this is about 5 years old now, and there was obviously some issues with the tissue because of biological width issues. We did some crown lengthenings. We did our socket shield. Same sort of technique. We packed bone. We placed it in the correct 3-dimensional position. And here you can see 4 years post-op, more importantly, what the tissue looks like. And again, you can see absolutely stunning papilla. You can see everything intact. And if we look at it from a CBCT point of view, you can see the incredible maintenance of the ridge here. And now you would say to me, yes, Howard, but again, it's a single implant and everything's great. And I'll say to you, well, it's not a single implant. It's actually 2 implants next to each other. And the critical issue now is it's not 2 centrals, because some people can get the same result without a socket shield with 2 centrals, not predictably. But more importantly is look at where that bone is at almost 5 years post-op, when in actual fact that's where it should be. And I think, again, this is the kind of technique that really shows us what the most phenomenal possibilities are with this technique. If we look at this case as well, this is a case that I did in 2014 when I placed the implants. I placed the implant adjacent. It was a Freeler 2 that I placed 12 years ago with an immediate placement. The classic scenario of recession, buccopalatal resorption. And here you can see 2014. If you have a look at that, 2015, 2016, the papilla between them is still there. The buccal bone, I need to put in this lecture, is still there and still unbelievable and intact. So frequently asked questions that I'm going to go through very, very quickly because we don't have much more time. But basically, the first one is, how long should the socket shield be? And really, there is no consensus on this other than to say it should be around 2/3 the length of the initial root. Hertzler have mentioned that it should be around 6 to 8 millimeters, but we go with a 2/3 the length of the root because that's you want to try and get as much as you can of the root to try and prevent that collapse. The second question is how deep should I place my implant? And you want to place it around 2 millimeters below the level of the bevel, as I showed you. Sorry, not a bevel, the chamfer. A bevel is not a good idea because a bevel still allows you to impinge on the shield. So place it a little bit deeper than you would normally, but make sure that you don't place it too deep, that you don't get that right emergence profile for the crown. Should I use, can I touch the shield? And obviously the answer to that is definitively yes. But obviously the one thing that you do want to make sure that you have is that S-shaped curve that we created, because that will create the prosthetic space. The bone will form between the two, as we've seen in both human and animal histology. But the key factor here is that we need to create the prosthetic space, because the prosthetic space will prevent the collapse. Endo gain versus no endo gain, I'm not going to go into that too much at this point. We don't think we need it at this point. We will see at a later stage. Do I need to fill the jump gap? It's still something that's we don't know. I do fill the jump gap because I want to get clot stabilization. Is it necessary or not? We don't know yet. Those are questions that we'll have to answer with controlled studies. And how high should I leave the socket shield? And this is something where in Barmer's study and Boozer's study they leave everything 1 millimeter. As Mitzias they leave it even higher with the Shompras in the Greek study. But I do believe that we should leave it at bone level, and the reason for that is to create the limitation of both internal and external exposure of the shield. How thick should the socket shield be? And this is something that I answered very early for myself, because when I tried to reduce it very, very thin, as you can see on the one on the left-hand side, it really created a huge problem with flexibility. And these are the ones where I had shield failure in 3 of the cases. And the minute we went to 2 and 3 millimeters of thickness, we got no flexion. And as a result, we know that 2 to 3 millimeters is really where we want to stay for this type of situation. The subgingival crown distance should be greater than 2 millimeters. As you can see in the CBCT, in both these cases, you can see beautifully healthy heel tissue. Failure to do this in CBCT, you'll see how the shield is actually touching the crown, and this is not ideal. And you can see the type of swelling and inflammation that you get here. And as I said before, here we use microflap raising, we cut back the shield and we put a small soft tissue graft into that to allow everything to heal, and that will help everything heal up very, very nicely. We can combine this with apical GBR. A lot of people say you can't do immediate implant with apical areas. It's absolutely not true. There's lots of data to show that you can, and it's whether you choose to or not is a different story, but certainly the scientific proof is there. We can do it. One of the main reasons there's a problem using when we do apical infection is because we cannot get primary stability of the implant. But here you can see this case where the patient wanted to have crowns done. These were ferrulous crowns. There was apical infection, really non-salvageable situations, and as a result of that, we did socket shields. We did the implant placement at the same time. We raised aesthetic buccal flaps. We took out the infection from both sides. We sterilized the area with laser and all sorts of things, cleaned out, curetted out, placed our implants, and just did routine apical GBR using Homley Wang's sandwich technique, and closed up. We couldn't get primary stability in this area, so we placed custom healing abutments, which is absolutely critical in any of these socket shield cases, and I would strongly advise you to do custom healing abutments or immediate provisionals rather than doing just a normal round abutment, because if you have to go and then push on the tissue, you don't know if you're pushing too much to actually start hitting the shield. So here you can see fabrication of the subgingival portion, creating the classic S shape that one would want with the provisional crown, putting it into position, and allowing that to heal. And this patient went away for a year, and when they came back, we did our ISQ levels, and we found very, very high ISQ levels of 80 and 85 of the implants. And you can see the emergence, and this is now a 3-year post-op case with the unbelievably beautiful rolled soft tissue that we have around here, and with absolutely zero collapse of the papillae, zero collapse of the buccopalatal dimension, no recession, no resorption of the ridge. And this is really what we want to have. The question is it going to last long term? In my opinion, without a doubt. Some people want the final proof, which is coming soon, and will certainly be here soon. If we have a look at the CBCTs, you can certainly look at what we have. You can see that we've maintained and we've actually healed those areas. Everything's looking good. And most importantly, if we have a look at the case, you can see here what the bone looks like. And I can't lie to you and say that these are at the same time as cementation, because you know that we had custom abutments for a year. So for the bone to stay there, it has to be something holding it there. And you can see where the bone should be. And again, this is something which is just unbelievable and unattainable utilizing any other technique other than socket shield. Molar socket shield, just briefly to show you what we do, is also something that can be done and something that I'm doing more and more of. I do these with raised flaps rather than with closed flaps, and they work really well. And you can see a healed molar socket shield again with unbelievable healing, with zero collapse of the tissue, and really a beautiful profile on which to work. The final thing that I want to share with you from the partial extraction therapy things is the Pontic shield. This was a technique that I developed. And really it was a problem that was associated with apical infections around where I wanted to do root submergence. So it's really just for Pontic sites, and really the indications for Pontic shield is where you have apical infection around a root that you want to submerge, or where you have a hyperemic pulp, in other words, where you have an irreversible pulpitis, or most importantly, where you have a necrotic or sclerosed pulp. And I learned my lesson the hard way, because I did one case where I had no bleeding when I cut the roots off, and it's the only 2 root submergence that I have lost over the 100 or so plus cases that I've now done since starting them in 2006. And here you can see intact buccal wall, again a critical factor as it is with socket shield, and these are really important indications for keeping everything intact. So just a short animation of the Pontic shield. Here you can see how everything's done. It's pretty much the same as the socket shield. There's no difference in anything that we do. We cut the crown off if the crown's not already there. We do the sectioning, the C-shaped sectioning of the shield, which allows us to remove the palatal portion as well as the infection. It's important to spend a lot of time curetting out the infection, making sure that everything's there, cutting it down to bone level. This is very important, must be to bone level, filling it up with bone. And then the next important thing is that we must do some kind of closure, either a rotated palatal flap or a free gingival graft, to make sure that we get good closure of the shield. And once that's done, then we get good healing. Once we've got good healing, as you can see, we can then place our Pontic into the area and get a very nice emergence profile without any collapse of the tissue. So here you can see one of the cases of Pontic shield. This is a patient who had a irreversible dentition, really just absolutely decayed and rotten. We decided to give her a overdenture because of the a hybrid fixed denture she wanted, and we wanted to try and maintain the tissue in the front, and we also needed to do some ridge splits, so we needed some mini implants. So we did 2 Pontic shields in the 2 centrals. We did a socket shield in the adjacent and a root submergence on the tooth next door to maintain the ridge. And you can see pretty much what we had there, and you'll see the same thing of what we have at a later stage. We cleaned everything out. We work extensively to clean it out. We seal the tooth that's got a root canal treatment with glass ionomer before we sink it. You can sink it with MTA as well. We did ridge split on the adjacent teeth, on the adjacent areas. We covered everything up. We placed mini implants in positions to hold everything in place. for the denture. And here you can see the beautiful denture, the beautiful healing of the tissue that we've achieved with expansion of the plates as well. Really nice tissue, and with exposure, with apical position flaps of exposure to get nice attached gingiva in the buccal, and removal of the mini implants and the final closure. And you can see here what implants and the final closure, and you can see here what that ridge, so we don't have to have a ridge lap, we don't have to have an area whereby we cannot clean. So this is something that the patient can clean very, very easily and very, very nicely, because of the fact that we've maintained the ridge using these Pontic shields. And you can see the long-term follow-ups of these ridges where we've pretty much maintained the ridges intact where they are. So that was a combination PET, and this is another combination PET case which I'm going to finish off with, and really just not going into too much detail, but this is a case where the bridge came loose at the back. We wanted to do some implants to restore. We wanted to do socket shield, the tooth next door. I wanted to root submerge, but there was obviously the possibility of an infection at the apex, so we rather did Pontic shield here. We did our Pontic shield, we prepared everything, we put our implant into place. Behind there we did ridge split, we did a sinus lift, we did all the necessary bone augmentations to create the right amount of bone on the buccal of the implant. We closed everything up using socket seal techniques. We were supposed to do Invisalign of the two anteriors in Germany where the patient lives, but unfortunately she fractured these teeth, possibly due to loss of the bridge, and we decided then to incorporate those two centrals in the we couldn't, the one was split in half, so we couldn't leave it, so we decided to take the other central and add it to the bridge so we could do an immediate provisional for the patient at this time. So here we did a root submergence. You can see the nice beautiful bleeding pulp, and we closed up with a rotated palatal flap, and we took an impression. And here you can see on the lower left, on the lower right hand side of the patient where they've got the collapse already, these three teeth will maintain. This implant was immediately placed, and these three have been exposed now after a year being submerged. And you can see submerged, and you can see at final impressions, you can see how beautiful the soft tissue looks. We've got our root submergence, our socket shield, the same socket shield over there. This was the lateral, and this is the canine where we had our Pontic shield. And you can see from this case, and this is about 2 years when she came for the final bridge, and we haven't seen her since then, unfortunately, but you can see how beautiful that bridge is and how stunning the soft tissue emergence is in this case, and how beautifully we've managed to maintain the ridge in that area and over there. And as opposed to the two implants in the posterior region where we had to do massive amounts of augmentation, very invasive surgery, in the front area we did minimally invasive, minimal cost, and we're getting the same result for the same return. So if you look at the lower right hand side, you can see the collapse of the tissue, so it gives you an idea of how badly this tissue would have collapsed had everything been done like that. And really a phenomenal case all in all. Here you can see the emergence of the crowns, really a phenomenal result. The papillae, we'll have to add a little bit of pink into those areas. Here you can see the root submerge. The papillae, we'll have to add a little bit of pink into those areas. The Pontic shield and the 2-3, how everything's been maintained. And really, again, with minimal effort, minimal intervention, and minimal cost to the patient, because of the fact that they didn't have to pay for massive grafting procedures, we managed to get a phenomenal case, which in my opinion is going to last. With everything sunk below the gum, no risk of decay, no risk of perio, we should have no problem to maintain that case 5 years, 10 years plus. And the question is, will we get less peri-implantitis because of the fact we've got less exposed surfaces of implant? I think that's a question that we'll see in the future. So in summary, this is a very exciting new development in implantology. There is still a lot of long-term results that we need. We need to look at that, but they are coming, and certainly the publication of our 128 case series, multi-center study, which is almost ready for publication, coming soon from our group. They are definitely a little bit more challenging techniques, but there certainly seems to be a wide variety of final morphology of the root, so it does give us a lot more variability in treatment and success. And certainly what I see from people doing on the internet, there's a lot of success from people who are doing these techniques, and so it is reproducible, which is the most important thing for us. With that, I say thank you very much for listening to me. If anyone would like to email me, docg@mweb.co.za, don't hesitate. If you're looking for any of the literature, I'm happy to share it with you. If you want to go to our website, www.implantacademy.co.za, there are a lot of videos on the technique, and certainly join us on Facebook. There are a lot of videos on the technique, and come to our Facebook partial extraction therapy page and join in the discussion, whether you agree or disagree vehemently or not. There's always great ways to have discussion, and I say thank you very much for this opportunity to share with the clinical masters. It's an honor to be invited to anything to lecture, and to certainly something with the group of guys that are lecturing with me. It's really an honor to be here, and I say thank you very much for listening.